diversity in healthcare. And I'm very much looking forward to this conversation with Dr. Margaret Larkins-Pettigrew to provide the best possible care for all patients and help minimize racial disparities. Medical professionals need to acknowledge and recognize the differences among varying populations. Diversity among physicians pertaining to social economic status, race, gender identity, and so on is key. PowerToFly's Lesley Carstens is joined by Dr. Margaret Larkins-Pettigrew the first Senior Vice President, Chief Clinical Diversity, Equity and Inclusion Officer of the Healthcare Network and Highmark, including their Enterprise Institute of Equitable Health in Pittsburgh, to discuss diversity in healthcare and why it's so important in these times, now more than ever. Welcome to Dr. Margaret and our very own Lesley Carstens.
Thank you, Hunter. I'm so excited to be here. And Dr. Larkins-Pettigrew, thank you so much for making the time to come. I am personally so excited about this talk, especially just given all that's going on in the world right now. And I wanted to kick this off by kind of having you, sort of frame the problem for us. I mean, I think everybody, I think most of the people, certainly the PowerToFly community, thinks there's something of an issue, but could you, like I said, frame it up and maybe even quantify it a little bit so people can really understand what the problem is?
Well, it's a great honor to be with you all today, and I like this whole title as Reboot because reboot means energize, change, to start again, and to refocus on where we really need to think about how we change what's been happening in our country for many, many years. And so when we look at the larger picture of how we got here is where we need to start, asking the question and thinking about, all of us, because we all live in the same country. I'm an African-American, you're white, you may be Caucasian, depending on the different ways we describe ourselves, but we all are living in a space where we know that there has been structural racism, right? Intentional structural racism from the beginning of how we now have the haves and have-nots, right? And so recognizing that we live in a society where it has been intentional to develop a structural racism concept that puts us in this place, especially in the healthcare system, where we really have to think about how we're taking care of all peoples. We have to start there. And that means that, when I say how we got here, is understanding the history of our country. Understanding, we can talk about 400 years of slaves, redlining, we can talk about the LGBT population and how they've had to strive, the women's movement. I mean, understanding all of that history really lands us smack dab in this issue of how we give good healthcare. Because until we understand the history, embrace it, acknowledge it, and then start to plan how we move beyond that, nothing will change. My hope is that things will change. This is a space in our society, especially, we were here at Allegheny Health Network, we were already thinking about how we make this more diverse and deal with equity. But since George Floyd, many people across the country are saying, we really need to take a look at this and focus on, how we got here, especially in the space where there should be no hate. It should be all about healing. So starting there, I think, is where we need to start this discussion today, because all of the things we talk about around, what we're facing today with disparities really requires that we look back.
Yeah. And I love how you framed that, so is there, and the questions I had were kind of more about today, but I just wanted to stop and ask, is there anything else you want to say about how we got here before we kind of dive into, what's happening today and, kind of to the point you made, how do we go forward, right? How do we improve it? How do we make it better and more equitable?
And I think that's probably the key, because we have to continue to educate ourselves as to how we got here, not only in healthcare, in businesses, in transportation, how we get to this space where we have this large disparity gap, this large wealth gap, this whole issue around why we have so many people in these disparate situations in both not only healthcare, but the health the comorbidities of health. How did we get here? And so in order to even get there and think about how we move from there, leaders in multiple institutions, whether it's large or small, we really need to embrace that history to govern, to be able to govern through a more social justice lens. And social justice is used, a lot, but it really is about how we decrease the disparity gap, thinking about the injustice and the lack of social attention that has been really given to many of these marginalized communities.
Yeah. Well, and especially since COVID hit, right? So I'd love to hear your take on how has that played out, in a pandemic, when, to your point, we're supposed to be looking out for the health of everyone and, but it doesn't always work like that. So what have you seen since COVID hit? Yeah.
So multiple layers of issues around why we need to be vaccinated, why we need to be all part of this. I would say that, all of us have to take this journey to be a more social justice society, use social data to really move into a space where we're making significant change so that we're all being taken care of. During the space of where we're in the pandemic, it really did show that we had such a large gap in not only access to healthcare itself, related to what's accessible, but also how we treat one another. And so all of that really came to a head where we have to think about how we take care of everyone, because we're all going to be, we all continue going to be affected by this pandemic. And when we talk about the pandemic, we think about not only the virus, but the vaccines, but the disparities, but then the social and political issues around that. And all of that comes back to healthcare, because even the social determinants of health result in the social determinants of life. What happens in our political arena affects what happens in our social arena around social determinants. And healthcare is smack dab in the middle of that.
Yeah, yeah. Well, and of course, we have the Affordable Health Care Act, which was supposed to address much of this and did do some good, but, we're still seeing numbers that indicate that African Americans in particular still have an unacceptably high rate of, lack of access to healthcare. And I wondered if you had any insights into why that is.
So the Affordable Care Act offered a lot of people the opportunity to access healthcare. We still have issues around why people don't access healthcare, even though accessing it is much easier today, right? And what happens and why people don't come to the physicians, why they don't come to the hospital systems. And that is around the distrust. And I think we had someone talk about that. And so why subject yourself to a system that will continue to not treat you with dignity and respect, and a system that may not treat you equally, and that doesn't understand that equity is not equality. I can give you the same test, but if I'm coming from a space where I don't understand what's going on, or I lack getting to spaces where I need to get the care, if that's not addressed as well, then it doesn't make any difference whether we have the Affordable Care Act for a lot of people. But in that same space, we also have immigrants and we have refugees that are still in the space who don't have access to healthcare. So there are multiple layers, but then since the Affordable Care Act, we have multiple decisions that have made in the social and the political climate that has really caused a large change in the Affordable Care Act. So there are requirements to even enroll, and so it's so many layers that now make many people who are already disenfranchised more disenfranchised.
Yeah, well, and I think you hit on something interesting, because we all know, from the data, that set and setting matters. And what I heard you say is, which I think is spot on, we can give the same treatment, but if the tone or the mood or the set of it is different, you're not going to have the same outcome.
Right.
You're just not. Yeah. Do you have any suggestions for, as a healthcare community, how do we start to fix that and turn it in the right direction?
So when I said at the beginning that we're all involved in this journey, right? And there's 3 levels of where we fit as institutions, as community, people in communities who engage in our healthcare system. And one is we have a monocultural community, where it's all about choosing the people who look like you, who speak like you, who do, you want those folks in your space. It's this affinity. And if you have a monocultural community, you you have a governance system that doesn't really address other folks, right? We don't want that system. So in the middle of this is this transitional cultural system where we're moving to figure out, let's see things through a different lens. Let's try to make sure we have intention to make changes that move toward better outcomes for everyone. And then we're, of course, in the space where there is this multicultural community where we're all thinking about social justice all the time. We're making decisions around how we treat everybody and how we give everybody the best care. And so most of us are in this transitional phase of trying to figure this out and how we do things better. But it has to start at the top. Who's the governance piece of this? Because those are the people who truly are the diversity officers, those ones who are making decisions about their own strategic growth, as well as making sure that they're taking care of the communities that they serve, that they're narrowing the disparity gap. So it starts at governance and how they understand how we got here, and then how they then begin to judge and to actually make decisions based on that.
Yeah. Well, I thought it was actually fascinating because I work with corporate America, and we're not working with as many healthcare organizations as I wish we were right now. But I was actually really impressed that they had somebody in your role in your organization, and I wondered, one, that tells me that the leaders in your organization are prioritizing equity, but like, how common is that? Do you have a sense for what percentage of healthcare organizations even have a, Dr. Larkins-Pettigrew?
I can tell you a very low percentage. First of all, I'm one of probably 2 physicians in the country that holds a position of a chief clinical diversity officer. It's usually someone who doesn't have a clinical background. I think people who don't have a clinical background can do a really great job. But I think that what gives me more insight is what happens at the bedside, as well as how I've been treated at the bedside. I'm an African-American who's been told by patients, I don't want you to take care of me because you're Black. I'm an African-American who's had lived experiences in a system that I have dedicated my life for, to say, do no harm. And as a professional, I have had pain points that have been subjected to me just doing this career. But I think that, all of that taken into consideration, there are very few organizations in this country, when you think about all of the people who supply medical care, that really have been intentional about making changes in their institutions internally, so that what happens externally makes a difference. So.
Yeah, I think that makes a lot of sense. And I'm curious, obviously, you're African-American. We've talked a lot about that, but do you have insights into how different the healthcare experience is for different, intersectional groups?
Mm-hmm. Oh, absolutely. I'm born in the 50s. I don't look like I'm that old, of course.
Yeah.
But I have
no, you don't.
experience that, with the healthcare system, with my family, and how my family members have been treated, and what has happened to the legacies of what comes with poor healthcare or lack of respect in a healthcare system. So the pathway to make sure that we are moving to a space where we're giving great care, and this is a healing space, is going to be long. It can't be a one-off. And so I think just to address a little bit of what happens internally, what I've brought to this system and why they asked me to come, is that I built this model, and it's called a transformational equity model that works internally only. So it takes all high-level leaders in your institution. They work in 5 pillars of what is happening in your own institution around the isms, sexism, racism, the gender suppression. Is there any place in your system that those things are rearing their ugly heads, right? So for instance, we talked about education earlier. Education is a big deal. How do we educate leaders, our governance, and how do we educate the entire system of workers, not only our nurses and our physicians, but our environmental service workers, our transporters? How do we make sure that they understand that they have to have buy-in, intentionality, to really see others in the way they are, to welcome people in their very authentic selves, and to build a belonging institution? So that one pillar deals with what we should be doing on a continuous basis to educate our leaders, and at the same time to educate our healthcare workers, all of them, and together to move into a space where we're thinking about it, how we treat people, how we how we actually uncover our own biases so we can deal with them on a day-to-day basis, working with our colleagues, working with our patients. And that's just one pillar, really important pillar. And just want to talk about one more is investigate. And it has three subcommittees. And one of the subcommittees is to look at what are our values, what are our core behaviors? Are we really making sure that that happens? And let's continue to advocate to bring people into our system that not only come here for a job, but to come here to specifically make a difference in the lives of the people we serve, to see better outcomes. One of the biggest ones we have, well, the second one is dealing with the political determinants of health. We talked about it as well. How does decisions made in the political space really affect the policies and procedures that we set in our own institutions? And we set on a day-to-day basis. Who makes a decision for someone to have the tubal ligation? The country, the government said you can have your tube side at 18 years of age. But at the bedside, who's counseling you about when and where you should have your tube tied? And if I have bias and I have a young 22-year-old who's had 3 children and is on welfare, the bias of, who's taking care of these people? Who's taking care of these children? Maybe she should have her tube tied, but who is that? Who am I to say that? Who am I to make that decision? And why do I take the autonomy from the patient by trying to consent them and counsel them and to do something based on my bias? That's just a small example of how the political determinants affect the social determinants. The biggest one is how we investigate any complaints of bias in our system. Do we have a structure that looks at it very honestly, very in a transparent way, and we make sure that we give everybody involved an opportunity to grow from this space? Not to fire people, but let's change together. Let's think about those attitudes that now have become behaviors that really shouldn't belong in our system. So that's just one of the other pillars. And it's so fascinating to see the outcomes of those as I work through this.
Yeah. I have so much respect for that. Yeah, just shine a light on it so everybody can see it. Do you have any advice for patients? I hear everything you're saying about the change starts at the top. I couldn't agree more. But, for the people who are trying to get healthcare, are there things that they can do to get a better outcome for themselves?
First of all, they have to make sure that they're in a space where they're feeling comfortable, that they have developed a partnership with some healthcare professional, in a real partnership where someone is listening to them, that they are educating themselves about who they are. The best person to give the best healthcare in any situation is the patient themselves. Because the patient has to come with, we listen to the complaints and we come up with what it might be as a diagnosis. But if you're taking care of your own body, if you're listening to your body, if you're writing down questions before you go into a physician's office, if you're talking to people who give you maybe different ideas of what might be going on, it's okay. But to have that trusted provider that you can go to and talk to and be very authentic about what you're eating, what your exercise pattern is, that is where you start with yourself and with actually getting a trusted partner that you can work with in the medical facility. And that's clinicians or whoever's taking care.
Yeah. So if you get a doctor where you don't have that, just keep moving on to the next one until you get it.
And do never feel guilty about being in a space where you're not comfortable. You move away from that space. It is okay because it is all about you and it's coming. You have to be comfortable. And so if you're feeling that someone's not giving you the right care and that they're not giving you the best explanations for what's going on with you, you do need to move on and find another trusted provider.
Yeah. And I love the other piece you emphasized about ownership. You really have to take that ownership because sometimes you're going to need multiple opinions. As you said, a doctor can just give you their opinion and everybody's got their areas of expertise, but being able to seek out multiple opinions, but then take ownership of that ultimate decision yourself. Yeah.
Right.
So I'm curious, are there, again, I think most of us, especially the PowerToFly community, there's no surprise that there's an issue in healthcare. But are there things that you find surprise people, or things that people don't expect that you can educate them about?
Mm-hmm. One really great example that I give is, how we as colleagues work together and try to protect one another as we give the best care we can, especially in this area of the pandemic. And the example I can give you is still today, in multiple institutions across this country, patients come in and we have teams of experts who are going to take care of them. Remember, we're really working hard in this space. And they say to that team, I don't want this person taking care of me. Someone who's wearing a hijab, someone who is, who may be African American, someone who may just be a female. And so what do we do with that? Most places don't have a policy to address that. They don't, and what they do is they want to give that autonomy to the patient, but they don't protect the team of experts who are going to take care of them. And everybody on that team matters, right? And so the bias of the patient then has the opportunity to really dictate how they're going to get their care. And it may be less care than they really expected, right? So, and that has happened across the country. What happens to that team if they move that individual away from the team who's taking care of them? The pain point that affects not only the team, because they've done that, and they think they're protecting the individual they removed, but what happens to that individual who's now removed from that team? That is a pain point they're never going to forget, because the bias from someone who came into this healing space, but then brought the bias that may change the team, right? And so the response to that is I hear people talk about it, and the colleagues that say, oh, I want to protect them. They're an African American and they shouldn't be subjected to this person who I believe may be racist or have racist behaviors. And then the employee who that was subjected to says, I love my partners, I love my colleagues because they protected me from that, right? Wouldn't it be great, and this is where we've moved to, is we don't accept that behavior. That we say, this is our team who's going to give you expert care. And we are not separating our team. And that this is what you have to accept being in our space, this space of healing, and a space that doesn't respond to hate. That individual has a right to leave that institution and go somewhere else to find care, right? Most of the times all of the times that I've uncovered this and I encounter this, patients stay, right? Because we are going to offer them the best care. But think about the bias that we have let come into our system. There's been lawsuits across the country about the refusal of care and what happens in that space. It's time for us to take a stand and not tolerate any other behavior internally, because it happens internally as well as it comes into our system. We want to be the best that we can be as healthcare providers, and we want to make sure that people who come into our system are the best. But to think about that dynamic that people don't have not considered. And
because everything we've talked about is the organization managing their issues and all the bias, but I mean the layers of complexity that factor in, because it's coming from both directions, makes so much sense. And I like, my jaw kind of hit the floor when you said we just stand up and tell that patient no. And I have so much respect for that, but I feel like I've been in customer facing roles my whole career, and everything you're taught is the customer dictates. Mm-hmm. But you're right. We do need to, if those are our principles and our values, then maybe that customer or prospective customer isn't a fit. Mm-hmm. But that takes
take a stand. But I think that it goes across all disciplines. I mean, if you do it in the business sector, the housing sector, you do the same thing. And then, people begin to realize that their behavior is something that's not acceptable in our society. That we're all biased, but we really have to dismantle the bias that hurts other folks. And I think that if from the leadership level all the way to our community and our partners, it is time that we really start to try to make those changes. And I don't want to dismiss patients who feel that way and who are biased. I want to educate them. I want them to take this journey with us so that we all end up being better for what we're doing.
Yeah. Wow. That's powerful. I was curious if you had any numbers that you felt would sort of help quantify the problem. Because I think that's one of the things I hear, when people, when you're talking with people about issues, they're sort of like, obviously there are a lot of issues to solve in the world, but when you can put numbers to it and they understand how big it is and the impact, I find that that's a very powerful way to get people to pay more attention to it. So I wondered if there were any, just any metrics or data points that you find to be especially helpful in really catalyzing people.
So one thing I want to say for this space of refusal of care, it probably happens in 90% of our institutions across the country. And how we deal with that is become one of the focuses or the foci that we're looking at, how we really have an algorithm to handle that. That's one thing. But because I'm in the space of maternal health and taking care of high-risk women who live with HIV, and taking care of just women who wake up every single day just to try to be the best they can, because I'm in that space, and we see such a disparity in the death of moms and babies in this country. You know, mothers, Black mothers are 2 to 3 times at risk of dying during childbirth in this country versus their Caucasian counterparts. Babies are at risk to dying 3 to 4 times more for Black women than for their counterparts. And in many places in this country, the rate is so ridiculous when you think about how we have not changed those percentages in so many years, right? And so here, it's about 13%, right? When you think about the rate of women, what rate of babies who are dying, we just think about Black babies. If we as a country, every country really defines their health of the country by the health of their babies. And we're living in a country where Black babies are dying and not seeing their first birthdays across this country. When you talk about the death of babies, if we decrease the death of Black babies, we know we can decrease the death of white babies and all babies, you know. But for us to tackle that issue, we have to be intentional. We have to understand how we got here. And we have to work on those components that make a difference in the lives of those women. Structural racism, preterm delivery, sleep accidents where people are not dying, babies are not dying from SIDS, babies are dying because they don't have a place to sleep. Why aren't we giving moms beds and cribs and pack and plays? Why aren't we recognizing those disparities in the healthcare of those women, social determinants of health, transportation, housing, etc.? And then the last one, postpartum. How are we sending women home without the support they need, without the mental support they need to deal with a newborn baby at home? And so that's one space where I deal with the statistics all the time around how we're going to move to positive outcomes. And so just amazing how you see these large differences in the healthcare disparities across the board.
Wow. Yeah, I had no idea.
Mm-hmm.
We actually have a question from the audience, which is, why are Black women so susceptible to death during childbirth?
So, and I covered some of them, but we know that one of the biggest issues when we talk about structural racism, dismantling racism, the voices of women and voices of Black women in this country are just not heard. I mean, we think about what's happening with Serena Williams, what happened with Dr. Johnson's wife, who was in the hospital system in one of our largest institutions in the country, and kept saying, my wife is bleeding and she's bleeding and she's bleeding, and no one listened. And she died in the hospital system. Beautiful, beautiful woman. We have so many stories of physicians who have given birth, who were not listened to, not taken care of. And so there's multiple layers in that space alone that we have to deal with, listening to the voices of women. And not only women, we have a whole transgender population that's being ignored, right? That also having babies. And so, when do we actually think about a society that accepts people who they are, listens to them, gives them dignity and respect so they can move through a process, being supported by family members, doulas, community health workers, and those organizations in the community that should be partners with all hospital systems, no matter what. And so when we think about why women are dying, especially Black women, it is multi-layered. It is about that social determinants, about preterm delivery and preterm labor and what happens in that space. The issue of toxic stress that many people don't talk about, the weathering effect that people have. We talk about weathering, and I'm going to break in a second about when you leave furniture outside all winter long, and it begins to deteriorate. We call that weathering. And that happens with Black women from the time they open their eyes in this country as children. They are mostly victims of ACEs, the adverse childhood experiences. They grow up with micro and macro aggressions throughout their entire lives, whether it's in school, whether it's at a job. And so they have this long-term effect of stress in their lives, and then they want to have children. So they already have an accelerated catecholamine. There's lots of things that are going on because of the toxic stress, right? And now they're in a space where they're supposed to be healthy and have a healthy baby. So they have much more challenges than others. So it's multi-layered. I hope I answered your question, but we know that it's multi-layered, multifactorial, and that we need to tackle it with all of the resources that we have available.
Yeah, wow. Are there any resources or books or websites that you recommend people who really want to understand this issue go dive into?
Oh, absolutely. Politically, just mom to bus policies that are being implemented. There's multiple doula programs. There's, so many things associated with just this space where where women are trying to make a difference in the lives of Black women. So, everywhere you look, we're talking about it because it's a major problem. I can actually send some links if you want me to after this.
Yeah, that would be amazing. Well, I can't thank you enough for being here. And also thank you for the work you do in the world. We need more of it.
Thank you very much.